Hello, my name is Dr. James R. Golding, and you're watching A Natural Healthcare Alternative, the program dedicated to your health, longevity, and well-being. Today's program is called Recent Advancements in the Fields of Reproductive Endocrinology. And with me today is our special guest, Dr. Alex Dlugi of the Sher Institute in Bedminster, New Jersey. Before I introduce Dr. Dlugi, I'd like to go over his curriculum vitae because it's so great that I have to go over it before we introduce him on the show. First of all, Dr. Dlugi did his undergraduate work at Yale. He got his medical degree from the University of Pennsylvania. He did his residency at Johns Hopkins Hospital, fellowship at Yale. He's a faculty member of Harvard Medical School and Tufts University School of Medicine, and was involved in the Henry Ford Hospital and Morristown Hospital. And when I originally met him, he was running the Bedminster Center for Reproductive Endocrinology. Now that location is known as the Sher Institute of Reproductive Medicine. And with us now is Dr. Alex Dlugi. Dr. Dlugi, thank you for coming back onto the show.
Thank you for inviting me.
We originally interviewed you a few years ago, and your center has changed name and has changed protocol. Could you tell us a little bit about your decision to make that move?
Definitely. When we first opened up our practice in 2000, my original intent had been to develop a practice and develop it to such an extent that we could then potentially look to join or affiliate or merge with a larger organization that could provide us with a lot more than we as an individual practice could offer to our patients. And by joining with the Sher Institutes, which is I believe there are currently 10 such institutes around the country, growing hopefully to probably close to 20 in the next several years, we now have access to many different programs and access to the latest in research technology that we can now bring to our practice and our patients in New Jersey.
This is kind of medical economics of scale.
Definitely, yes.
And now, so this was all part of the master plan. Originally, was to get things going and then to merge with a larger organization like this.
That was my plan.
I've heard from doctors that it's really reproductive medicine is very much about the lab. The quality of the lab. I mean, has changing to this organization, has that brought you a greater ability to do different testing, different procedures?
The laboratory itself is really not that different. I mean, we built a true state-of-the-art facility 5 years ago and have maintained it as such. But what we have access to now are some things such as the following. There is something that is referred to as an embryo marker expression test, which measures a protein called HLA-G. This HLA-G is secreted by approximately 16% of embryos. But if it's present, and we test for it by sampling the culture media, which is the liquid in which the embryo is growing, and everybody always worries, oh my God, you're going to do something to my embryo and send it off. But the embryos are too young to travel. We sample the media and actually look for this protein. And if it's present, it appears to indicate that this is an embryo more likely than not to implant. So what that allows us to do is to be much more selective when it comes to transfer time as to knowing which embryos to recommend for transfer. Under a most ideal circumstance, if we grow our embryos out to day 5, which is referred to as a blastocyst culture, and they have this positive marker test, our pregnancy rates are over 80%. So it's actually rather phenomenal.
Well, that is terrific. So it's not always that an embryo developing to blastocyst state is the choice embryo for implantation.
Correct.
Size is not always the factor.
It's not always the factor. There are many different factors. One of the things that we've discovered in the last 2 years, as we've been part of the Sher Institutes and have had access to their research laboratories, is that it appears, at least in preliminary data, that embryos that are not able to make it to the blastocyst stage are probably chromosomally abnormal. So a lot of information coming out now that's going to affect what we do.
So growing out better, allowing the embryo to grow out further is generally a better thing.
That is my belief. It is.
Okay.
People argue about it, and one of the concerns that many programs have and patients have is, suppose on the third day in culture there's some nice-looking embryos, maybe we should transfer them.
Catch it while
yes,
hit it while
if we
it's
go
hot.
to day 5, they may not make it, and oh my gosh, we have no transfer. My take on it currently, and obviously this is all individualized, it's not our decision, it's a discussion with our patients. But even if there's only 1 or 2 embryos, if they can make it to a blastocyst stage, they're much better off. And if they don't make it, there's probably a very good reason for it.
Right, and that might not have happened anyway.
Exactly.
And frequently I've heard women, make comment that, well, he's not sure whether the transfer is going to be on day 3 or day 5. What is then your criteria? I mean, why wouldn't the norm be the idea of day 5?
Because it's really because many patients are afraid of going to day 5. And with the use of this HLA-G marker test, if on day 3 we have some nice 7, 8, or 9 cell embryos that are expressing the marker, and we transfer them on day 3, we have a 70% pregnancy rate. So a lot of it comes down to also, it's an emotional issue, and it really comes down to the patient making a decision. How important is it for her and her partner that they have a transfer, or do they go out to day 5 knowing that if we do have a transfer, the pregnancy rate is probably better, and yet they may not make it and there may not be a transfer. And my argument there is, what is better for you? Do you want, if it's important to have a transfer, then transfer. If you are willing to understand that while we hope you're going to be pregnant, but if you're not, you're going to know immediately and not have a false expectation and have your hopes dashed 10 or 12 days later.
Right, or be upset that
Exactly.
that the outcome didn't work.
Yes.
Is it more likely that you're going to encourage a blastocyst state if the number of follicles extracted is greater?
Yes. I mean, the more eggs there are, the more embryos there are, then the greater one has to select the best embryo. Now, just to tell you what's coming down the horizon, probably within a year, that will be exclusive to the Sher Institutes, and I can't tell you too much because it's still in preliminary stages, but unbelievably exciting, will be our ability to extract the eggs, to test those eggs for their complete chromosomal component, to freeze those eggs, to subsequently thaw them, fertilize only the normal chromosomally normal eggs, and a limited number, because we're seeing that, again, in preliminary studies, about 98% of chromosomally normal eggs will make it to blastocyst, and they are all chromosomally normal blastocysts, and have the ability to transfer 1 embryo, or possibly 2, and have a 70% or better pregnancy rate.
That's a lot of major medical science going on right there.
That is going to be probably revolutionary and change the way this is
I would say that it is too, because I look at reproductive endocrinology as a set of hurdles at each step along the process that needs to go on to the next thing. So when I've discussed with women about these, it's like, don't be thinking about your next meal when you're digesting your current meal, and just one step at a time.
Yes.
But it's kind of a heartache then to be successful to the degree in which implantation occurs, but then there is a genetic issue
Absolutely.
that appears to come up,
Yes.
separate from what can be picked up earlier. It's an additional emotional letdown,
Absolutely.
separate from the highs and lows that it seems to characteristically go hand in hand. what is it that you're looking for that determines that this egg quality when we're saying A, B? What is it that you can tell? What is it?
At this point, assessing egg quality is very difficult. It's very difficult. Even eggs that we think are perhaps strange looking, they're dark or granular, may well fertilize and produce a normal embryo. The evaluation is mostly of the embryos and looks at division rates, symmetry of the different cells, at what point in time have they become a 7, 8, or 9 cell, at what point have they become a blastocyst. And at the blastocyst stage, one can actually tell a little bit more because one actually begins to see the formation of the fetus within this cell mass. And sometimes it's absent, or sometimes it's abnormal looking, and those are embryos that should not be transferred.
It's amazing that on such a small level that the amount of detail that can be extracted.
It's fascinating.
It's hard for me to imagine even the tools necessary to extract samples. When we're talking about micropipettes and stuff like that, it's hard to imagine that it can happen on such a small level.
Yes.
There appears to be a connection between the immune system and infertility.
Yes. What we are looking at, and it's interesting because that entire area is very controversial. And what we have found, again, since joining up with the Sher Institute, is that you have to look in the right place. And part of the reason that the whole area of reproductive immunology has been controversial is that there are no well-controlled, randomized scientific studies that truly answer the question. And a lot of the early literature came out of a few groups whose names I won't mention, but let's put it this way, they're a bunch of shysters who just published this ridiculous stuff and how they did all these crazy treatments and what wonderful success rates they had. And the problem with those studies was that if you looked at a general population, the pregnancy rates were no different. So they really couldn't make the claim that their particular treatment did anything because it was no different from doing nothing. On the other hand, there is a very small subset of patients who have either had recurrent pregnancy losses, who have perhaps done an IVF cycle or 2 or 3 and not been successful despite what appears to be truly a transfer of beautiful looking embryos, or who may have conceived with in vitro fertilization but had a very early pregnancy loss. And what we're finding is that there are a variety of different immunological components to this that may actually affect implantation, including overcompatibility between the male and the female. And by that I don't mean an eHarmony sort of thing, but an immunological thing, meaning that for, let's say, a kidney transplant, you would like to be as immunologically close to the donor as possible. That's not good for reproduction. There has to be some difference so that the mother's immune system can recognize that something is going on within the uterus and trigger an appropriate cascade of immunological events to allow this embryo to implant. And when those events are thrown off kilter, there are means to treat this as part of an IVF cycle. And we have found in our practice, and I will tell you that until we joined with Dr. Sher, I was not a believer in this until he explained to me what he was doing and the fact that this is so narrowed down to a select group of patients for whom it's effective. That several months into our joining, we brought back some of our patients with that particular history, treated them, and they've been successful. I mean, it's amazing. Again, is it cause and effect? Is it scientifically proven? It's not, but it's fascinating.
What is it that you're testing? And do you then also have to test the husband?
Yes, we do. We look at things like something called natural killer cell activity. We look at immunophenotypes, HLA-G, a whole bunch of scientific mumbo-jumbo. But basically what we're looking at are immune mechanisms that play a role in the actual attachment of the embryo to the uterine wall. That's one part. And the second part that looks at the very early development of the blood supply between the embryo and the maternal circulation. And there are different antibodies and immunological events that can be looked at, which, if present in abnormal activity, can then be modulated.
Okay, so this isn't something that would be requisite or a requisite component for the majority of the women that you're
not. I would say in our practice, maybe 5% of our population qualify for even the testing.
For those types of
yes.
Those types of things.
Correct.
Well, what else is new? I mean, I can't believe that what you were telling me before, that with the, being able to predetermine the genetic set prior to,
yes.
Would couples that are, let's say, in a window where they want a little refractory period between having kids, but the woman developed, let's say, 4 or 5 good embryos and got pregnant with IVF, they could save those eggs and use
yes.
those later? And
absolutely. In fact, one of the things that the industry is looking at and that people talk about as the next wave, if you will, is in effect having a library or a storage facility for eggs, meaning that in theory a young woman could have her eggs retrieved, genetically tested so we know which ones are normal. You put them away in the freezer. She then goes on to fulfill her career and everything else
yeah.
that she would like to do, and not have to worry as much about the biological clock anymore.
Yeah. It's kind of drifting a little bit, but I want to pick up on that yes. because it was a topic in New York Magazine, a few months ago, yes. freezing your biological clock.
Yes.
And I was wondering whether, have you come across any a woman that was looking to do that?
Yes.
That was in it.
Yes.
So that has actually occurred.
Yes. People are looking and asking.
Do you?
And I'll tell you what other, if I may just interrupt, is another role for that is a patient who's about to undergo chemotherapy or radiation therapy for a malignancy, has not yet had a family, would like the option in the future where we can get those eggs and have them available for later use.
Wow.
Yeah.
Just the dynamics of what can open up with that. I've noticed that the protocol of the medications that are given to your women patients seems to be more involved than it was prior, or there's more.
It's not really more involved. It's different. We used to, in the past, run our program 24/7, which was exhausting for everybody. And we are now doing it in groups. So we run about 9 to 10 cycles a year. There are pros and cons to it. The cons are, we do hear from patients who come to see us today, well, gee, maybe I can start next month. And we say, well, gee, we're building our August cycle. Oh my God, it's so far away. And yet what they don't understand is there's a whole preparatory process in order to get to an IVF cycle that takes about 2 to 3 months to complete. So we're really not that off schedule.
Just as far as preliminary blood
yes.
work,
blood
past
work,
medical history,
exactly,
all of those
yes.
things.
Cultures and pap smears and that type of thing. But what we're finding with the new protocols is, for us it's an economy of scale, and we can be much more efficient because we know exactly when we're going to be concentrating exclusively on the IVF cycle without the distraction of other types of visits and concerns. Number one. Number two, for patients, they will actually get a very colorful, detailed calendar, so they don't have to guess anymore, well, gee, maybe my retrieval is going to be here, but maybe it's there, and how do I plan my vacation? What do I tell my boss? It's very scheduled, and a lot of patients do find that very helpful.
They don't have to put their life on hold
exactly.
as much for that.
Yes.
Another thing that I think that's been an advantage is that you have then someone that goes over that particular schedule with them,
Yes.
shows them,
Absolutely.
how to do the medicines and stuff like that.
The hands-on in our office is very strong. Our patients spend hours with me and my nurses. Everybody is given one-on-one education. It's
what I was mentioning before, separate from the cycling of patients,
Yes.
moving them along as groups, and the advantage of, core focus during that period of time. I've noticed that the actual medicines themselves are separate from like Lupron or one of the some of the more recognized medicines, seem to be more advanced. That it's more of an intricate process now. Is that
well, everything is individualized. There's nothing that's cookie cutter. Number one, the medications are changing because the pharmaceutical companies are making advances. They're more recombinant products, for example. Our protocols are somewhat different from what we used to do. Our initial suppression of the ovary is not quite as intense as it used to be. And some of the protocols now are allowing us to take women who are, quote, poor responders, who've had elevated FSHs, who would probably in most places be told to go to an egg donor program. We've actually been amazingly successful in taking these women through a cycle, retrieving eggs and having pregnancies.
So you're happy with the jumps and the leaps that have been going on in the profession? Sounds like it's almost almost difficult to keep to keep abreast even when you're doing it all the time.
Just to give you a perspective, when I started doing in vitro fertilization in 1982, the pregnancy rates, and we were thrilled by this, were approaching 5%. And women were doing, 9, 10, 15 cycles to get to that 5%. And now we're talking, 40, 50, 60, 70, on the right circumstance, 80% pregnancy rates, most of them within 1 or 2 attempts. And what's coming down the pike, is, as I said, is going to be absolutely amazing.
And this all in a relatively short generation since, I remember it was almost like a political thing, test tube baby, or, that type of thing with the advancements. But the reason for doing this is it almost seems to be extrapolated, with the way in which things are turning over and those changes being made.
Absolutely.
Now, on a chart like this, I got this the other day because I thought that this was a fancy, colorful chart that helped to give a visual explanation of some of the reasons, why. What might a person like yourself correct in what they're saying as far as reasons for male or female infertility? I see that male infertility is a 35% component. Is that pretty much?
Most people talk about 40% male, 40% female, and 20% being a combination of the two.
All right, and but the other factors, as far as when we're saying unusual problems, this is that component that may deal with the immune factors. Also I've heard about people just there's other incompatibilities just with sperm-egg incompatibilities. I mean, would that?
Yes and no. I mean, the sperm-egg issue is overcome by doing ICSI, or intracytoplasmic sperm injection. So that is a virtual non-issue. I think what people talk about a lot is so-called unexplained infertility, meaning that couples have gone through a workup, they've really found no cause. And I think it's a misnomer. It's not really unexplained. There is an explanation. We just don't know what it is. And through the process of in vitro, we are finding errors in fertilization, errors in early embryonic development. I suspect that we're going to find a lot of chromosomal errors. In fact, I will tell you what's absolutely fascinating is that when we've looked at presumably normal, whatever that means, young women, egg donors, and have looked at their eggs and analyzed them for their chromosomal component, you would think that these young egg donors are probably going to have a large number of normal eggs. 70% of the eggs are chromosomally abnormal. Okay, we as humans are very poor at reproduction. And as women get older, that percentage climbs even higher. And I suspect that a lot of patients who are having good IVF cycles and what we think are good embryos and are not getting pregnant, I would bet that it's because the chromosomal component is not normal.
Kind of sounds to me as if you're working on it, though.
Yes,
you know, you're working on
absolutely.
that factor.
Yes.
One last question before we wind it up is that as far as for the male factor,
Yes.
when we have decreased motility, what's maybe decreased or just a change in morphology, you know, that type of thing, does that necessarily mean that the underlying genetic constitution or material is defective just because the numbers are low or the motility is low? Is there
Not necessarily, but possibly. Meaning that we do see a lot of male factor infertility. We have a lot of successful pregnancy outcomes. On the other hand, sometimes it doesn't work. And we're going to be able to know if the egg is normal or not. It is still impossible to do the genetic testing on sperm. That will be another huge leap.
Oh, that? Well, that would be a
very
pre-testing right
yes.
there.
Yes.
Almost it could be like the premarital blood work or something like that.
Yes.
Where I mean,
Yes.
who knows where the direction of that will be?
That will not be in my time.
But for Natural Healthcare Alternatives, I'm Dr. James Golding. And Dr. Dlugi, I'd like to thank you for coming on the show today. And I'm sure you find that really, really informative. Have a great day.